كيف بس أكبر لك إياه ولا برزنتيشن؟ كده ما حتيجي البرزنتيشن.
Just put it on
كده البروجرام present.
Okay, again, we're going to start with the mechanism of lung injury, valvular trauma, and mechanism of villi, just to review what we've said in the previous lecture. Transpulmonary pressure and strain is proportionally related to change in volume over the resting lung volume, which is the functional residual capacity. The more change in volume causes distension, and that causes injury, especially if you have low functional residual capacity, which will cause atelective trauma, recruitment, de-recruitment injury. And that results in stretching of the collagen fibers that leads to microfracture of the extracellular matrix, inflammatory signaling, and vascular stresses that lead to tissue wounding and inflammatory activation, which leads to lung injury sequence. We'll discuss this. So, in order to prevent atelective trauma and recruitment, de-recruitment injury, we probably need to use higher PEEP levels. But sometimes if you use too much high PEEP, even with normal tidal volume, you may also cause overdistension. Even with high frequency, in one study when they used too high mean airway pressure to overcome all atelectasis, this study resulted in poor outcome with more mortality in high frequency oscillatory ventilation. So the aim when we're using high frequency oscillatory ventilation is to use, to ventilate the baby with mean airway pressures in the green zone here to avoid, to recruit as much lung as possible, to avoid recruitment, de-recruitment injury, and to avoid atelective trauma, but also we tend to avoid to reach the overdistension or ventilate the baby at the total lung capacity in this also injury zone. So we try to ventilate in this area. With using high frequency, you can achieve both because your mean airway pressure is supposed to be above the closing, critical closing pressure for the lung, which is what we call the open model. But at the same time, we're using small, tiny tidal volume so that we avoid overdistension. So in one hit, you can really prevent both valvular trauma and atelective trauma, at least in theory. And if we increase the lung volume above critical opening pressure to the optimum and keep it there in inspiration and expiration, this may result in homogeneous gas distribution, reduced regional atelectasis because you have recruited as much possible of the air sacs, and you have maximized the gas exchange area and pulmonary blood flow, which leads to better matching of ventilation perfusion and reduction of intrapulmonary shunting and subsequent reduction of oxygen exposure. The benefits of decreased tidal volume usage to less or equal landed space in high frequency results in enhanced gas exchange due to gas transport mechanisms that are just different than conventional ventilation. There is no excessive volume swings, and there is reduced regional overinflation and reduced valvular trauma. So that's in theory, and let's see what the clinical studies have demonstrated with a Cochrane review on the elective high-frequency ventilation compared to conventional ventilation in the early stabilization of infants with respiratory distress. In this meta-analysis Cochrane review, they have accepted 19 eligible studies, about 4,000 infants in those studies. The conclusion is that high frequency is a way of providing artificial ventilation of the lungs that theoretically may produce less injury to the lungs and therefore reduce the rate of chronic lung disease. Although a small protective effect towards the lungs can be seen, this moderate benefit is highly variable between studies and should be weighed against possible harm. And when we say highly variable, but that's obvious if you look at some of those studies. And I usually bring the example of two major studies, one done in the US, I think by Johnson, and the one done in Europe by Courtney. And the one that was done in the US showed decrease in lung injury and chronic lung disease, whereas the one done in Europe showed the other way around. And there is a major difference in the design of those studies. The US study used SensorMedics, which is an active piston-driven active expiratory phase as well as inspiratory phase. In the studies done in Europe, mostly they use just regular ventilators that have an added passive high frequency to it. They only used active expiratory machines like SensorMedics as a rescue therapy. The guidelines, the protocols were not really established in the European study, whereas they were established in the American study. So again, when you put these together in the meta-analysis, it's not fair, and you just dilute the effect. In some studies, there was an increased risk of severe IVH and BVL, but the overall meta-analysis revealed no significant differences between HFOV and CV. The short-term neurological morbidity with high frequency was only found in the subgroup of 2 trials, not using a high volume, meaning not using an open lung strategy with high frequency. Most trials did not find a significant difference in long-term neurodevelopmental outcome, although there is one recent study actually that showed reduction of the risk of cerebral palsy and poor mental development. The limitations of this review, that it was carried over a long time period, 25 years, during which changing obstetric and neonatal practices may have influenced the conditions under which the study was performed, and the outcome has changed. Participants in early trials could be up to 34 weeks gestation, so they used higher birth weight, higher gestational age weight, whereas more recent studies use more immature infants, more at risk for chronic lung disease, who may not have even received the steroids, so that they are at higher risk of chronic lung disease with more severe lung disease as expressed by an index of oxygenation. So there is a lot of variation in those studies. The interventions varied markedly by type of ventilator, as I have mentioned, passive flow interrupter or piston, and the strategy used for high frequency. Over time, it was more likely that high frequency was delivered using a open lung technique, which would be likely to improve the effect of high frequency, while conventional ventilation was more likely to be delivered using lung protective strategies as well, which could reduce the comparative effectiveness of high frequency. So that's why, in conclusion, although there's insufficient evidence exists to support the routine use of high frequency instead of conventional ventilation for preterm infants with lung disease who are given PPV. So presently, the preference for a specific ventilation mode remains open and remains a matter of clinical judgment. Those centers who are used to high frequency, they are experts in using it, they continue to use it, that's fine. And those who do not have the experience probably should continue to use conventional ventilation. How about using high frequency in babies who are born at or near term? We don't have any randomized trials for that, and such trials are needed. But however, when infants fail conventional ventilation with persistent poor gas exchange on high support, high frequency offers an alternative mode of ventilation that may provide better ventilation and oxygenation in the neonate with severe respiratory disease. Some people like to say if you're using PIP above 28 or 30 or MAP above 12, maybe it's a good point to switch to high frequency. Operation. Now, In the state, the only high frequency that is FDA approved is the Sensor Medic. I know here you have other ventilators. You have also Draeger that has, it's not a piston driven, but at least they claim that the expiratory phase is active. So more or less similar to Sensor Medics, but not probably as powerful. What knobs we need to adjust depending on oxygenation and carbon dioxide. That's the aim of ventilation, is to oxygenate and remove carbon dioxide. The reason we approach oxygenation and carbon dioxide by using different knobs on the ventilators, even though they are both gases and both share the molecule O2, is that oxygen is partially negative molecule, whereas carbon dioxide is a neutral molecule, and neutral molecules, they are fat soluble. And since we're talking about diffusion across an alveolar capillary membranes composed of phospholipids and fat, carbon dioxide diffusibility is about 20 times more than oxygen. And therefore, the rate limiting step for carbon dioxide is not diffusion. It is actually removal of the molecule from the air sacs out, which is how much air volume, which is tidal volume, and how many times you can do it in a minute, that's the rate. So what determines carbon dioxide removal is tidal volume and rate. And what determines tidal volume is the pressure gradient. In conventional ventilation, it's the difference between PIP and PEEP, but the pressure gradient in high frequency, you have a knob for pressure gradients called power. That's easy. For oxygenation, you need pressure to push oxygen across the membrane. So you need a mean airway pressure and, of course, FiO2. So that's why they are different. In high frequency, it's easy. You have an FiO2, you have MAB knob, and for CO2, you have a delta P knob and frequency. Now, for the frequency, the only difference in conventional ventilation, when you increase the frequency, you wash out more carbon dioxide. In high frequency, when you increase the frequency, your carbon dioxide will accumulate more. The reason for that, we're talking about very high rate, 600 per minute, so the I time, E time are too short. They are much shorter than the 5 times constant, which is the minimum amount of time required to complete an inspiratory expiratory phase, and therefore we do not complete those phases, and the tidal volume would be critically affected whenever you increase the frequency, because the times are shorter and you affect the tidal volume. And that's how whenever you increase the frequency, your carbon dioxide accumulates more. And remember, when we say pressure gradient on high frequency or the power, it is the wave is, so we say power of 30, that is, the wave will be dampened through the ET tube and narrower air passages to probably by a factor of 10. So 30 will be 3 by the time it arrives to the smaller bronchioles and alveoli. Mean airway pressure, amplitude or power. Oxygenation is a function of FiO2 and MAP. Ventilation is a function of frequency and tidal volume. So higher mean airway pressure means higher oxygenation. Higher amplitude or power means lower carbon dioxide. And higher frequency means higher carbon dioxide. As you can see here, this is the wave. These are the volumes underneath the curve. You can increase the volume by increasing delta P, so that washes more carbon dioxide. But if you decrease the frequency, you allow for more time, and that gives you more volume. So decreasing the frequency will result in more tidal volume and wash out of carbon dioxide. I just want to note that sometimes you may be ventilating the baby at a very high mean airway pressure or very high power, leading to overdistension. So you're at total lung capacity. Whenever you reach that point, things become different. So at that point, you are not really delivering enough tidal volume because you have a cutoff of the expiratory wave here, and therefore you will start seeing increase in carbon dioxide that is related to maybe even mean airway pressure. And as well, at that point, because of the overdistension, you may have increased pulmonary vascular resistance and shunting and hypoxia because of using high mean airway pressure. The answer to that Usually we'll see some dampening of the oscillation on the chest on the baby. The X-ray will show overdistension. Babies may also have hypotension because of decreased venous return and decreased cardiac output. So the answer to all these changes is to decrease the mean airway pressure rather than keep increasing your power to overcome carbon dioxide accumulation. How you set it, you start MAB 2-3 centimeters above the mean airway pressure on conventional ventilation. If the baby was not on conventional ventilation and you're just starting with high frequency, you may start at 10 and go around that. Then you increase your MAB by 1 to 2 centimeters until your oxygenation is appropriate at FiO2 of 40 to 60%. This allows you to know that you are in an open lung model. If the baby is requiring more than 60%, probably the baby needs more mean airway pressure to open the lung and recruit more alveoli. Set the frequency to 10 hertz. Some people like to set it at 15 in extremely tiny, small babies to use smaller tidal volumes. Then adjust amplitude to get an adequate chest wall vibration. And inspiratory time in sensor medics, we use 33%. In the Draeger, they recommend to use 1:1 or 1:2 ratio. Obtain a blood gas and chest radiograph, and then adjust the knobs depending on whether there's poor oxygenation or under ventilation or over ventilation. With poor oxygenation, we try to increase the MAB, not the FiO2, and keep the FiO2 below 60%. With poor ventilation, we try to increase the power rather than the frequency. Unless your power is maximized, then you may alter the frequency. Chest radiograph, the initial chest usually in the first 2 hours to determine the baseline lung volume. We like 8 reps, follow-up chest X-ray in 4 to 6 hours, and then as needed. Weaning, reduce the FiO2 to below 40%. Some people even like to below 30% so that you are sure that you are still in an open lung model. And then before weaning the mean airway pressure. Then reduce the MAB when chest radiograph shows evidence of overinflation, and reduce the MAB by 1 to 2 centimeter increments to 8 or 10 centimeters. In air leak syndrome, maybe you will wean the MAB over the FiO2, wean the amplitude by 2 to 4 centimeter increments. Do not wean the frequency. Discontinue weaning when MAB is 8 to 10 centimeter water and amplitude about 20 to 25. If the infant is stable at that time, you can extubate to CPAP or non-invasive ventilation. Suctioning is indicated if there is diminished chest wall movement, elevated CO2 or worsening oxygenation, suggesting airway or ET tube obstruction. If there is obvious secretions, of course, avoid it in the first 24 hours unless there is clinical indication. Use inline suction so that you don't lose volume, and press stop button briefly while quickly inserting and withdrawing the suction catheter. When you press the stop button, you stop the oscillation, but you maintain the PEEP actually so that you don't deflate the lung. Currently, there is an ongoing study on non-invasive high-frequency ventilation in newborn infants. This is a Cochrane meta-analysis review. They're trying to address several questions in using non-invasive high-frequency oscillatory ventilation. Thank you.
Thank you, Dr. Ramzi. So now we will open the time for discussion and question. Prof. Paolo, Dr. Ramzi.
Please, do you have any questions? Just raise your hands. Yes, please. You can start.
Okay. Thanks for the two speakers. I will start with Dr. Ramzi and then Paolo Manzoni. We start to have the habit to extubate the baby from high frequency to conventional and then extubate him. You mentioned a very important point to extubate directly from high frequency CPAP. I don't know what's your experience on that aspect. The second question is about Many of our junior, they will call us, okay, you allow us to do permissive hypercapnia, but what is the level of CO2 that you will accept it? We say, okay, 45 to 55. Now you are teaching us hypercapnia can cause IVH and brain injury. How we can balance between these two, hypercapnia permissive and the CO2 limits, or the highest, safest CO2 limits?
Yeah. The first question, yes, you can extubate from high frequency to CPAP or high flow, and in my practice, I usually do that actually, and it works very, very fine. There is no need to go to conventional as a transition. Your other question regarding the CO2 levels, we have to differentiate between the first couple of days of life and then later on. In the first couple of days of life, it's very sensitive time for IVH, and tend not to, I mean, both hypo or hypercapnia can lead to hemorrhage because of the direct effect on the tone of the cerebral vessels. So in the first 3 days of life, most people keep like 45 to 55 probably. But after that, you can go up maybe 50 to 60. And then in the chronic lung disease, later on, I mean, as long as the pH is maintained above 7.2, and depending on how much support you are, if you're on high support and you have a baby who's chronic lung disease, we accepted 70s, even 80s when they are 6 months old or so.
No data to tell us the safest CO2 that you can reach it, and it's very variable from 45 to almost 70s.
Right, because we're talking about different patient population now. If you have a 6-month-old infant who's chronic lung disease, who's still on high ventilatory support, 70s with maintenance of pH above 7.2 is fine. There is data to support that, actually, that it's lung protective. Even higher than 70, some people accept, because the price that you are paying is to cause more, increase your support, which is going to cause more damage. Whereas in a fresh baby, in the first 3 days of life, except 45 to 55, I think. But after that, maybe 50s to 60s are okay.
For Professor Paolo Manzoni, at one time we get confused between American Academy of Pediatric guidelines and the European. Nowadays, we are in Saudi, we are confused between the national guidelines, which is American Academy of Pediatric, and CIPRO guidelines. So as external evaluators, which one we should follow, which one you feel more practical in following?
Okay. Well, I think it's a difficult question to answer, because it may be the same as it happened in Italy when we developed guidelines and recommendations on the management of bronchiolitis